So the next session will be on specimen, and it will be taken by Dr. Shirshak Datto.
The next session, after a most important session on COM, this is the session on specimen. A table in MS exam is a specimen. Firstly, different college have different specimen, and the same for laryngectomy specimen, different college specimen is different. So after a gross knowledge, gross discussion, you have to see the specimen of your own center. I think all the centers are home center now. So there is no problem, the specimen is unknown to you. So specimen should be known to you. If you have to see the specimen in your college, in your center. But the gross things are same. So first thing, I am not going to discuss about the disease, because the disease have the separate sessions. So this session is all about how to present and what are the crossing questions about the specimen. There are two specimens in this institute. Mostly all of the institute have these two specimens. One is larynx specimen and another is maxilla. Because these specimens are easy to obtain and easy to identify. Otherwise, if a thyroidectomy specimen is given, it is very difficult to identify as a thyroidectomy specimen, because it is a soft tissue mass just. So first, some basic norms during presentation of in a table of specimen. That first, it is a preserved specimen and preservation solution is there. So if you tilt it, it may spill off. So first thing, don't lift up the specimen off the table and don't tilt it. You can rotate it just like that. So you have to rotate it to see all the four surfaces of the specimen. And how to describe it, how to describe the specimen. First, identify the mother organ. What is the mother organ here? What is the mother organ here? Maxilla. So you have to keep in mind what are the types of maxillectomy first. What are the types of maxillectomy? Anyone please? Partial or total? What are the partial maxillectomies? Infrastructure or medial maxillectomy. So what is this? It is specimen of complete maxilla or not? Partial. What partial maxillectomy done here? Infrastructure, because the orbital plate is not there. The superior roof is not there. Floor of the orbit is not there. So it is infrastructure maxillectomy. So how can you describe it? First, it is a specimen of maxilla obtained by, now total maxillectomy or some partial maxillectomy. Obtained by, it is here infrastructure maxillectomy. Apart from maxilla, any other thing is there? So you can describe all these things. How many teeth are there? You have to mention it. And showing, now coming, after describing the specimen, mother organ, along with the associated other attached organ, other attached structures, you have to come into the disease. So what is the disease? It is very difficult to show the disease in a camera. There is a mass within the cavity of axillary antrum, within the maxillary antrum. So you have to describe which wall is involved. Which wall? Definitely the superior wall is not involved, because it is infrastructure maxillectomy is done here. Definitely the superior wall or roof is spared. So what are the other walls involved within the maxilla? Mainly inferior wall or floor and lateral wall. Also you can say medial wall. It is very controversial because the mass is not very well defined in the specimen at least. Is there any break in the wall, you have to say? Is there any break? Yes, there is a surgical break in the superior wall, in the roof. That's why you are calling it is a infrastructure maxillectomy. But there is no pathological break. So the next question is, what is inbox tumor? What is the advantage and what is the disadvantage of inbox tumor? What is in-box tumor? Maxillary CA is called in-box tumor. So advantage is if you can remove the box as a whole, the disease will be eradicated. This is the advantage of in-box tumor. What is the disadvantage of in-box tumor? Often it is very delayed diagnosis because that mass is within the maxilla, there is no symptom apart from similar to rhinosinusitis. So there is no specific symptom initially. So often it is delayed diagnosis. And then you have to say what is the staging. I am not going to discuss about the staging because there is a separate session on maxillary carcinoma, maxillary CA. So you have to say the staging. To see the staging, you have to firstly see the any involved wall, involved broken wall. If it is within the box, definitely there is a downstage. If the medial wall is broken in any specimen, it is better to describe it as sinonasal carcinoma rather than maxillary carcinoma because it is difficult to say what is the origin, in nasal cavity or in maxilla. It is better to say then it is a sinonasal carcinoma. Then you have to, the question, theoretical question will be cuts of maxillectomy, staging of maxillary carcinoma, cuts of maxillectomy, cuts of different medial maxillectomy, cuts of total maxillectomy. Okay. And this is specimen of what? Larynx along with, now along with, what are the structure along with? Thyroid. We have to see whether both lobe of thyroid are there or ipsilateral lobe of thyroid is there. To say whether it is ipsilateral, you have to first identify the tumor. So don't go for description in a hurry. So see the specimen properly, see the mass, identify the mass. You have to plan what will be your answer when the question is what is the specimen. So you have to identify the mass first. Where is the mass here? Is there any mass in the larynx? So there must be other reason for total laryngectomy apart from laryngeal carcinoma. There is hypopharyngeal carcinoma. Hypopharyngeal carcinoma is also an indication for total laryngectomy. So is there any mass apart from laryngeal cavity? This one, pyriform fossa. So pyriform fossa is involved here. So what should be the description? So it is a specimen of larynx along with what are the other structure? Hyoid bone and just rotate it. Thyroid cartilage, thyroid gland. Mainly it is ipsilateral thyroid gland. Generally ipsilateral hemithyroidectomy is done. The larynx is intact or open. Cut open posteriorly. Cut open posteriorly. Generally this opening of the larynx is done for visualization of the mass in postoperative specimen. But in this specimen there is no mass within the larynx, it is a pyriform fossa tumor. So cut open posteriorly, if you have mass in the within the larynx in your specimen, then cut open posteriorly to show a mass. What type of mass? In both maxilla and larynx, what type of mass? Ulceroproliferative, proliferative, what? Huh? Why not ulceroproliferative? Ulcer cannot be uttered in a specimen, postoperative detached specimen or postmortem specimen. It is not, you cannot say postmortem, it is preserved specimen. So ulcer can only be mentioned in a living body. Ulcer is a pathological process. So cannot be an ulceroproliferative mass. It may be proliferative mass, it may be a space occupying lesion, it is proliferative mass. Occupying which pyriform fossa? Which pyriform fossa? Right pyriform fossa. So what will be the staging now? So we have to remember the staging of supraglottic carcinoma, Dotic carcinoma, subdotic carcinoma as well as hypopharyngeal carcinoma. Hypopharyngeal carcinoma, how many subsites are involved? That is the determinant of staging. So how many subsites are involved here? How many subsite? What are the subsite of hypopharynx? So what is the how many subsite involved here? Only pyriform fossa. Then why total laryngectomy done here? If it is only pyriform fossa, it is stage 1, TNM T1. So T1, is it an indication of total laryngectomy? No. Then why total laryngectomy done here? Yeah? Yeah, I cannot determine that staging in a specimen because the clinical staging involves the direct observation of mobility of the vocal cord. So I cannot say, sir, I cannot say the staging exactly because I cannot check the mobility in a specimen. That will be the answer. So most probably it is stage T3 minimum because total laryngectomy is done. T1, T2 is not an indication of total laryngectomy. If not extensive neck involvement, then neck dissection along with total laryngectomy may be done. Or neck may be addressed in other way by radiotherapy or. And then the question is about the total laryngectomy theoretically, and in this specimen, another specimen is there. It is also specimen of larynx. So please, anyone can describe it? Key specimen, what specimen? Wet mount specimen of? No, not specimen is not for total laryngectomy, obtained by total laryngectomy. So larynx along with if it is a freshly mount specimen, the anterior muscles may be visible. So if it is visible, we have to mention the muscles. What are the muscles is usually attached with the laryngectomy specimen? Mainly 3 muscles. What are those? So you have to mention the name of that muscles if it is clearly visible to be attached. And thyroid gland. What lobe of thyroid gland? চাপা পড়ে গেছে বলে এটা চাপা পড়ে গেছে now you have to describe the mass. Where is the mass here?
Probably involves the right knee fold, the true cord, and also the ventricle, and also the false cord.
So what is your diagnosis? What is be the possible diagnosis? Is it a possibility a pyriform fossa tumor invading into larynx?
Yes, sir, there is also.
So what should be the better term covering both these? Marginal zone cancer. Marginal zone cancer. It is very common in our Indian subcontinent. Marginal zone cancer. So what will be the staging here? T3. Again, in the specimen, always if you can tell, if you want to tell the staging, possibility, most probably these terms should be attached with your answer. Because you cannot determine, because for staging, assessment of vocal cord mobility and the CT scan, both are necessary for staging. If it is only clinical staging without radiology or radiology is included. and another staging is pathological staging. T3 or T4? Can it be T4B? So from specimen I cannot say, but from theory 4B is an indication for palliative treatment, not for a total laryngectomy. So generally the next question will be about the laryngectomies. What are the mainly the if a larynx is totally removed, what will be the complications?
The first complication that we have to make up for is the voice of the patient, the quality of life of the patient. So we have to make up for the quality of voice, and then we have to make up for the swallowing the dysphagia management that is occurs after post-op laryngectomy.
Why there is dysphagia in a case of total laryngectomy?
Because larynx takes part in that is the laryngeal elevation takes part in the swallowing
Which
phase
stage?
of,
Which stage of swallowing?
laryngeal stage of
Laryngeal?
there is no laryngeal stage, there is pharyngeal stage of
Pharyngeal
the
stage.
swallowing.
Actually,
There
it
is
is
elevation of
actually
the
acting as
larynx.
a suction pump during
Yes.
elevation
Elevation of
and
the larynx
depression.
causes the
So
suction
there will
of-
be a problem in deglutition. Any other problem after total laryngectomy?
we have created a defect, we need to reconstruct it with some kind of flaps, and also there
What defect?
that we have removed the larynx, we have removed the thyroid, we have removed the strap muscles. So there is a
Skin is intact.
the skin is
Skin is intact generally. So
Yeah.
there is no flap reconstruction is required generally with total laryngectomy. Flap reconstruction required for total laryngectomy? No.
no sir. But if there is a probability of a pharyngocutaneous fistula, we have to go for a
Postoperative complication. I am telling about what will be the inevitable problem of a patient after total laryngectomy. Like voice. One
I
is
said,
voice.
sir. Voice said.
Voice deglutition.
Voice
And
regurgitation. And
huh?
and
Aspiration. To prevent, in another, apart from the indication of
done a prophylactic-
laryngeal carcinoma, often total laryngectomy done to prevent aspiration.
yes sir, we have done
So
already a
aspiration is not a postoperative problem.
we have already done a tracheostomy. So
Yeah, it is endon tracheostomy is done. So there will be no possibility of aspiration apart from accidental ingress of something. So what will be a very, very important problem, not a complication, problem. Not a complication, I am giving you hint. Patient is a manual labor.
sir, dependence sir, dependence sir. Dependence sir,
No, he cannot hold his breath. So he cannot lift heavy weight. Breath holding is impossible in a total laryngectomy patient. So it is impossible to breath holding. Heavy work needs breath holding, or there may be some problem in defecation. Okay. Now other complication, it will be definitely a theoretical question. In viscera, apart from theory, the question is very minimum. You have to present it properly. You have to present it and never tilt up a specimen, never lift up a specimen. You can only rotate, see whole of the specimen, what are the attached structure, what is the mass, where is the mass, and a possible staging you have to determine. Then you have to present and ready to face for the operation steps and operative complication. I think for specimen this is enough. Huh? Smell, yes, sir was mentioned smell. Because patient is taking respiration through the tracheostome, there is stoma, there is no use of olfactory area. There is no exchange of gas, respiratory pathway through the nose. So there is the smell sensation, and definitely if the smell sensation is lost, the taste sensation will be hampered. Okay? Thank you.
Thank you, Dr. Shishab Dotto, for a deliberate presentation on the specimen.